right, so that's the first clip, the first part of the clip. Second part of the clip is me putting him on the table. So you can see me talking to him and pointing at his knee and pointing at his foot. And what I'm doing is, in my head, I'm saying, what position is his knee and his hip and his ankle and his foot and his lumbar spine in? And what muscles do we test, or what NFTs do we do in those positions that correlate with certain muscles? Because I'm going to put him back on the table after we already worked on things. I'm going to put him back on the table and check a couple little things to see if we can fine tune. So I put him back on the table. First thing I checked was vastus lateralis, because when he's in that position and he's talking about his butt pulling away and his ankle, his heel popping up, he's putting himself in the position for vastus lateralis NFT. Put him in that position, he's failing, okay? Not like he totally gives out, but he's got a little stutter and a little fail. So you'll see me, I palpate that, recheck that, good. Then I put him in the position for two other muscles that are in similar positions. He passed both of those, so I didn't treat those. So I flip him over. I want to check soleus, because that would give him more dorsiflexion, or would cause soleus inhibition would cause the heel to lift up off the ground. So check soleus, fail soleus slightly, treat soleus, got him right back up, redo the swing, and I was like, yeah, it feels like if I had that line there, my butt is staying on the line. I feel stable in this position, and the position was the position of vastus lateralis, and it feels my heel is on the ground. Okay, so that's how easy it is to assess and tweak and maximize function by maximizing physiology when you know how to do that. So I didn't guess and think, oh, I wonder, well, let's try this and let's try. And so I didn't give him a corrective exercise, because if I gave him an exercise when he has inhibition, he would just figure out how to compensate and work around the inhibition and make things worse. I didn't force him to get into position. So a lot of times physical therapists will see their patient move and they'll say, oh, that movement is dysfunctional or tight. We have to give you more motion. We have to give you more flexibility. So let's force you to get into motions with either passive range of motion or manipulation or stretching, or that's tight, that's limited range of motion. Let's allow you to get into that range of motion, which means we have to take away the tightness with stretching, massage, foam rolling, Theragun, which lets them get into the position because now they have no neuromuscular control. Now the muscle is dysfunctional. And what's muscle's two jobs? To either stabilize a joint or move a joint. So now that we made it dysfunctional, it can't stabilize the joint or move the joint. Even though the joint has more range of motion, it just has flexibility. And what's the definition of flexibility? Range of motion without control. Good idea? No. Okay, so if you want to know why golfers have bad backs, is because they see PTs that stretch them and roll them, and their personal trainer Theraguns them and tells them they need more flexibility when they don't. All they need to do is break down the motion that feels tight or looks limited, break it down to its physiological components, address those, fix those, reassess the motion, see if now they get in and out of the end range of motion in the transverse plane while they're weighted down by gravity. Hopefully these sound familiar because you were in our 3-day challenge and I talked about these things on day 2. And that's how easy it is. So instead of guessing and thinking you see something that you actually don't, and thinking that you need to fix something that you actually don't, and when you do those things, using things that actually make patients worse, instead of doing that, use a thought process that breaks motion down by the muscles that control the motion, because if the muscles don't control the motion, then the motion is dysfunctional. Okay, that's the root cause. Okay, get to the root cause, neuromuscular dysfunction. Reverse that, get him right back up, retest it. Then after we got done doing that, I just had him roll through his exercises that he already knows how to do for those muscles that we worked on, and said, okay, so this is when you feel your butt pulling away from the line or the heel popping up, these are the go-to exercises. So now he has tools to use when I'm not there. So when people say, well, manual therapists are just making patients reliant on them, so they have to keep coming back for therapy. Correct. If the manual therapist is doing stretching, massage, manipulation, passive range of motion, those are all things that the patient has no thought process and no strategy to attack those when they are on their own. I gave him a thought process and a treatment strategy that he can check what he's doing. And when the checks fail, he has a self-treatment and then a recheck to make sure that what he worked when he did the self-treatment actually worked. That's not building dependence, that's building independence. All right, so there's the breakdown of the golf swing reel that I just posted on Instagram. If you haven't seen that, now go watch that and see if that makes sense. See you next time.